Jesse Chason with Lisa Blanchard as the host of Airing Addiction.
I share often my journey started on this campus. Got sober as a client here, just like you.
I really do see phenomenal change.
Always hope. I've seen situations that on the surface look impossible become possible.
Doing this podcast is to share those recovery stories, be honest about what the challenges are and have some real conversations, but kind of share that out on the airwaves. Welcome, everybody, to today's episode of Airing Addiction. If you are listening to us live on Facebook or shortly after we air this episode, you will know that it's Nurses Week. And that is really the point of our episode today. It's also Mental Health Awareness Month in May. And so I think it's a wonderful opportunity to talk about the intersection between behavioral health, mental health, substance use, addiction, and nursing, and recognize two fabulous nurses that we have on. So I'll turn it over to my co-host, Jesse, and let Jesse introduce everybody.
Thanks so much, Lisa. Good morning, everybody. And yes, I'm really excited to have both of our very special nurses on today in celebration of Nurses Week. Also, like Lisa said, there's so much more going on here at Spectrum Health Systems and New England Recovery Center regarding substance abuse treatment and recovery with nurses. So today we are joined with by Brandice French, our Director of Inpatient Nursing here at Spectrum Health Systems, as well as Michael Oliveri. He is a nurse with Community Partners Program. And just to kick things off, guys, I'd love to give you some time just to share as much as your story as you would like. And then we'll go into I'm sure we'll have some comments or questions, Lisa and I. So to kick things off, why don't we go with Brandice first? Good morning,
Morning,
Brandice.
Jesse. Thank you for having me. I've been here at Spectrum for almost 6 months now. I have been a nurse. I graduated Fitchburg State in 2011. And I actually changed my career paths. I had wanted to be a lawyer and decided to go into nursing after I saw, very good experiences with family members and very poor experiences with family members. I always knew I wanted to work with underprivileged people. So my first job was at a county-run nursing home in rural New Hampshire. I also volunteered at a men's house for LGBTQ men with HIV, AIDS, and Hep C, and other, serious issues. From there, I did a stint in a rural emergency room and did hospice for a while. And in 2017, after my mother died of an intentional drug overdose, I decided I really wanted to make a difference in mental health. So I went to CHL as a nurse manager and just fell in love with working with addiction. So I became board certified in addiction medicine and got my master's in nurse executive leadership, because I feel like being a nurse leader can truly make a huge impact, because you're not only impacting clients, but I'm impacting nurses. And by impacting nurses, it trickles to clients, especially with this population. Most people with substance use disorder are not treated well, I think, by nurses. There's a lot of stigma and a lot of judgment, which is truly heartbreaking because of, as a nurse, you take an oath to treat everybody equally and kind, and that it doesn't say, well, but if you shoot heroin, we're not going to treat you nicely. I never read that. So, it's really my passion to empower nurses and educate nurses about stigma and about addiction, because in nursing school, I'm sure Michael can speak to this too, we get really zero education. So all of our experience is based on what older nurses are teaching us when we get out into the world and our personal experiences. My other passions as a queer person, I do a lot in the queer community with LGBTQ care and trans folk, especially African-American trans and Hispanic trans youth. Those are a big area of research interest for me. So the LGBTQ community really even gets a even kind of crappier end of the deal for substance use. I've had a lot of trans clients when I worked at CHL be scared to be trans on the units because of how they would be treated. So, my passion is educating and empowering nurses to make sure they give this population and all populations the fair treatment, and really they deserve, above and beyond treatment, I think, from nursing and from the medical field. So, and I also am on the board of directors at a recovery center in Leominster, Montachusett Recovery Center. So I do a lot through them too. But those are my passions: are LGBTQ care, addiction, and I also do a lot for people who have lost a loved one to suicide survivors.
Brandice, that's absolutely amazing. I can't wait to dive more into detail. I'd love to maybe just have us hear a little bit about Michael's background, because I think that will lead to some great conversations about what's been similar, what's different, and how the nursing field has evolved, over the years, particularly in addiction care. So, Michael, would you want to share a little bit about your background and how you landed back here at Spectrum?
Yes. Well, no, thank you so much for having me as well. I have been in nursing for over 40 years. I first graduated in 1978, my first program. And I've been with Spectrum, actually. I started with Spectrum in 1980 as a per diem nurse in their old facility at the Worcester State Hospital, second floor detox. And as a 23-year-old kid at that time, it really did have an impression on me and what addiction was and getting the true meaning of it. Then I've gone on to different venues in my career. I worked mainly in Boston at teaching hospitals. I was at Shriners Burns for 20 years. I was doing research nursing at the Mass General Adult Burn Unit, ICU, and at Brigham and Women's for 12 years. And I think, just to say, to reemphasize what Brandice said about the way our clients are treated in the emergency room, I was one of those emergency room nurses, not the one you're talking about, Brandice, but I saw it a lot, and it's truly upsetting. And I had 2 emails today from clients that are in the emergency room saying that they're not being treated, right, or they don't feel they're being treated correctly. So it does go on, and I would love to be able to be a part of changing that, that whole atmosphere of our clients in the emergency room. And so then I'm back here at Spectrum. I've come full circle. I was a wonderful position with the Behavioral Health Partners of Metro West. We're a group of care coordinators. I'm one of 3 registered nurses, and we have around 10 or 11, 12 care coordinators, and we work very closely as a team and to work with our clients in the community and to educate them, get them more PCPs and appointments with psychiatrists, therapists. And it's truly a really very, I think, well-run community-based program out of Spectrum. I'm just proud to be a part of it.
So, Michael, that was actually for my master's thesis. I was going to educate ER nurses about nurse stigma, but COVID. So I was hard enough for me to get in there in the first place. And they were like, oh no, COVID, you can't come in. And I'm like, So I actually did it on detox nurses and did education to detox nurses about stigma, because you see it even in the ATS level of care. But yeah, that was supposed to be my master's thesis project for the ER nurse.
Oh, yes. Excellent.
So what's exciting to me is that really one of the primary goals I see of the Airing Addiction podcast, right, is to combat stigma, right? That's part of what we try to do kind of within every episode, regardless of the guests, regardless of the topics. We've actually done an entire episode on recovery language. We had Dr. Miriam Komaromi from Boston Medical Center, the Grakin Center on, and Julie Burns from the Rise Foundation, really talking about kind of the language. And I wonder if, especially with your length of experience, Michael, and even what you continue to see now, Brandice, but what kinds of recovery language issues do you see, right? Like there's been a shift in medical care from what I understand. You guys are much more embedded in kind of the medical setting than I am, of not referring to individuals as their disease, right? Instead of saying like the diabetic in room 12, right? You're not going to use that language, and that we're trying to also transition in the chronic disease model of addiction, right? Which we should all be following at this point, that we wouldn't use that same language, right? Labels and descriptions of individuals. Do we still see that? Like, do we still see that in emergency departments and in spaces, words that I personally would never use, but for descriptive purposes, the addict in the, ED, do we still hear some of that?
So I can give you an example that's less than a year old. I had a client at my past job who called us from the ER, and, she's schizophrenic, very mentally ill, had a relapse. And she goes, these nurses aren't treating me well. And I know could be difficult. And so I'm like, I'm in the area, let me go down. And by the time I got there, she left AMA. And I won't say exactly the verbiage the ER nurses use, but it was definitely, we don't have time for those people. And they use the J word. And we actually need to see sick people. And I'm like, oh, okay. So I did some education on the point that I said, so you'd be okay if this woman left and died by suicide or an overdose because she's not sick in your mind? I was astounded that people this was 2021, were using language like that and were blatantly saying to somebody who they didn't even know, we don't have time for your clients. We have actual sick people. Astounded.
I think that's even, it becomes even more sensitive when our clients will present to the emergency room as what we call frequent flyers. And, they're going, maybe I've had clients show up 4 or 5 times in an emergency room. Every other day, I get a ping, I get a notification of someone in the emergency room that could be there every other day, and they're going in for the same reason. And of course, a lot of these clients, there's that mental health component. And I think what Brandice was saying, about a patient or a client that has suicidal ideation, well, wait a minute, you don't consider that being ill? And you want them to section them or do something to hold on to them before they put them out onto the street, because a lot of these people are homeless and they really have nowhere to go. So I think educating the medical community is one of our first things that I like to do. I'm calling hospitals. I have 30 hospitals in my phone on speed dial, all for the emergency rooms or ICUs to get transferred into, to talk to the nurses and to follow up with our clients. And so I think that that's really an important thing of being able to do that, even in a very small part, in a very small way. That makes a difference, because I'm speaking now to some of the same nurses. I spoke with one this morning at Mass General, and I said, what was your name? He told me his name, and it was a German name. I said, oh, we've spoken before, so it's getting to that point of repetition, and they get to know who we are and what we're doing.
And I always point out, and I'm honest about this, I have a presentation, I can email it to you if you want, Michael, aimed toward nurses about stigma and the neurobiology of addiction. But, when I was an ER nurse as a new grad, I can give you examples when I was unkind to people with substance use disorder because I was uneducated and I didn't know. Right. I had a woman come into the ER and I never asked if people did drugs because I just assumed, I'm like, I'm in my early 20s, like, who does that? Like, we're in Vermont. And she was pregnant and vomiting nonstop. And I was like, I'm going to ask today. Why not? And she's like, I have a heroin problem. And I probably made a face because she looked down and looked shameful. And to this day, and that was like 9 years ago, I can remember every detail of that encounter. And like, she goes, I really wanted to stop. And I went to my doctor and he told me to titrate myself down, but I don't know how to do that. And I want help. And I was like, we're going to give you help, but just, I must've made a face. And I still think about it to this day. And, that's not what she needed. And that's not what she wanted. And I was not a good nurse in that moment. And, I kind of wish I could find her and say, I'm so sorry. I hope, now that like, based on this, I'm trying to do better for other people. And, thank you for pointing out that I was being, judgmental, but nurses need education and they don't get it.
And the lens, I think, one of the things that I, even with our own staff and our detox programs, right? But I think it's the same, and especially for emergency departments who have been very overburdened and very stressed out in general. And then we add the layer of the pandemic and everything else that has gone on to that, is that the lens of addiction is only seeing individuals with substance use disorder at their most vulnerable, right? And their most symptomatic. Because that's when you're presenting to the emergency department, when you don't have resources, when you don't have what you need. That's when you're presenting to an inpatient, detox, withdrawal management. And because those are such short term, either even if it's 5 to 7 days in a detox or short term ED, and you only see people cycle in and out, you don't get to see the other side. Right, mm-hmm. Which is that recovery is possible, and that that individual could look very different. Right. A month later, 2 weeks later, let alone kind of a year out, working on recovery. And it's hard to see it through that lens when what you're faced with is the most acute and vulnerable.
What I educate nurses and staff on, because I could educate about it for hours and days, like I'm sure you probably could, Michael, is think about it this way. I said, when these people were kids, do you think they grew up saying, because you say they have a choice, I want to be addicted to XYZ. I said, nobody, wants that. Nobody wants this chronic health issue. They're not aiming to be that way. So just keep that in your mind that, they're struggling and this isn't what they wanted for them either, but they're in it. And it's difficult to see that when you're in the throes of active addiction.
In picking up on that, I think that I was a preceptor at the Brigham and Women's for many years, and I would get a lot of new graduates. I actually worked on a floor that hired all new graduate nurses, and they had a couple of senior nurses, such as myself, being the charge nurses to mentor these new graduates. It was a great program. Unfortunately, I don't think it's running anymore, but I would tell these new nurses that when they walk into a patient's room, that they should see their mother, their father, their sister, their brother, their partner, whomever in that bed. And that's how you would treat that person. That's who they are. And that's always been my introduction for a new person going into nursing. And
that's a great way of looking at it.
Well, it's worked for me over the years. I will say that,
I'm also thinking of, the nurses, not only that we have here, but, you can't go too far without running into a nurse, whether, we all know people that work in the field, but even if you don't work in the field and you're just listening to this, this place would come to a screeching halt without nurses, but we just assume that we go to any ER and there's people there to help, right? And where do all these people that want to help come from? Well, I have to think that they're looking at the patients kind of like Michael was looking at when you're in nursing school and you just have this desire to help. Very similar to what we do here with, specifically mental health and substance abuse treatment. And, I'm thinking of the people personally that I know in my life. My own mother-in-law is a nurse, and we were talking before we kicked off here. She's been a nurse for 40 something years. Love you, Mom. And she recently retired, and then she came back because she couldn't stay away from helping people because that's what she feels like she needs to do, right? She gets something from that. And clearly all of us here on this podcast get something too from helping people. But just if you're out there and you're listening and you're not really sure the underlying motive, or maybe, why do you do this job that seems like it's extremely stressful, intense, high burnout rate, right? I'm sure Brandice and Michael, you could go on and on and on about the things that you've not only experienced firsthand, but, seen firsthand from others, peers and mentors. But just if you both could talk a little bit about maybe what continues to motivate you or drive you in this field to continue on.
You go first, Michael.
Good for you, Brandice. Touche. What continues me? I'm pretty much like your mother-in-law. She's been a nurse for over 40 years. This is my 44th year. I can't even think of retiring. I wouldn't know what to do if I retired. And this program at Spectrum has really opened up the most perfect opportunity for me to give back what I've learned over the years, my knowledge, my wisdom, compassion over the phone. I mean, people can come through over the phone. And what we do here, I think, is just a great journey into the community. But also for me, I wouldn't know what to do without nursing. I sound like a nursing nerd, and I am. To me, there's no other profession. But I mentioned this. I'm a third generation of my family nurse, my grandmother and my mother and myself. And now I'm very proud to say my niece, who has a master's in business, is looking into nursing. So that could be the fourth generation. So just as medical people, doctors, they say, oh, I'm a fourth generation doctor. There's something to be said about four generations of nurses.
Certainly.
I always knew I wanted to do it. It was not easy in the early 60s when you're telling second and third graders you wanted to be a nurse, and all the boys wanted to be police officers, firefighters, and astronauts. So, yeah, I knew always.
Michael, I wonder if we could talk a little bit about the program. So I have had a lot of involvement in the community partner program, so I know it well, but just so our listeners know what this is, it's really part of the evolving healthcare landscape in the state of Massachusetts. And it's a program that is focused on having, behavioral health providers kind of as experts in that area, provide community-based care coordination services. So for the most high risk, high need individuals in the state, it's really about kind of having a community-based support that brings in the whole care team, that connects with the, we've heard Michael clearly talk about kind of talking to emergency departments and talking to hospitals and kind of being both an advocate for the individuals that we care for, but also bringing in the supports. And because so often, our patients are individuals with substance use disorder, it's really combating that stigma, right? And being that support in even the medical communities and other areas where they might not have a voice, right? If it weren't for our support. So, I just wanted to make sure folks kind of knew a little bit about the program that Michael actually has been part of since the kickoff, 4.5 years ago. Right.
It's an amazing program, and again, I'm just so I'm thrilled to be a part of it, especially from the beginning. To watch something grow as it has is amazing, and our connection now with the community, I think, is tenfold of what it was when we started 4.5 years ago. We've had to hire new staff, more nurses. There's just so much that has been added to this program. But the one thing that is continuous is the dedication of the staff, the people, the care coordinators, the social workers, the secretaries, the nurses, that when we reach out to the community, that's our goal, is to bring them in. And I think by what I have seen over the past 4 years of these clients who have never had it, well, they haven't seen a PCP in 10 years. They don't have a therapist, or they don't have a psychiatrist to write them the psych meds, that we're able to get, our care coordinators are able to work with them to get appointments for a PCP, for a psychiatrist, for a therapist. And they're seeing, instead of going into the emergency room as a revolving door, they're seeing their primary caregivers. And that is really the greatest, the goal of what we have in this program, is to decrease emergency room visits and to connect these clients in with primary caregivers and people that will continue to see them on an ongoing basis. And it's being done.
That's great, Michael. I was thinking a little while ago when you both were sharing about, ER visits, and you even said, some people show up every other day and you get notified about this. Really, being somebody in recovery, I can only imagine that patient coming in and, just wanting help, just in crisis mode, not knowing where to go, where to turn. And, ER, for lack of a better term, almost becomes the dumping ground where, you get 911 called on you, the police take you to the ER, or, the EMTs take you to the ER. And then it's like, what then? And if we have these nurses that are, whether they're not properly educated or, whatnot, they're turning these people away, or like, the story you told about Brandice, where you had a client call you from the ER and then leave AMA because of it. Well, we're not really solving the problem that way. We're solving the problem with programs like you just talked about, Michael, where, that same client motivation remains true. I just want help. I need help. I don't know where to turn. And instead of showing up to the ER every other day, well, I'm going to get a PCP. I'm going to get a psychiatrist. Maybe I'll even get a therapist to see somewhat frequently. And I'm going to be stabilized on medications. And I know from this seat, what we do here at Spectrum Health Systems in New England Recovery Center, we see that almost every day. The benefits of people stabilized on the correct medication, stabilized on the correct treatment care, and not just surviving, but thriving. So kudos to you for being involved with this for 4.5 years since the inception, and really, seeing this thing just grow.
I wonder if that's a good opportunity, and I'd love to hear what Brandice and Michael, of course, have to say. But I think it's helpful during Nurses Week to both recognize how valuable nurses are in all areas, but also to highlight if somebody was thinking about going into nursing school, was thinking about going into behavioral health or addiction, and what can that nursing role look like? Like, what are the things that nurses do in the space of addiction treatment?
So I feel that's something that nurses should be made aware of, that no matter what field you go into, like even if you're a labor and delivery nurse, which is what all the kind of people are like, ooh, that's what I want to do. You're going to work with addiction. You're going to work with mental health. Like, there is no field of nursing that you're going to go into unless you do like maybe MDR nursing, where you're just like doing straight paperwork for people, or pharmaceutical nursing, that you're not going to be dealing with people with addiction or mental health. So to me, like, educating nursing that, even though I went into nursing school, I didn't want to do anything with mental health. And I realized, well, this is like in everything, so you can't not want to do it. You have to kind of be aware of it and do it. And so I would educate nurses that if they are interested in mental health and addiction, to take extra classes, go to extra conferences, ask to shadow people, volunteer maybe at like a halfway house or like Jeremiah's Inn or things like that. Go to meetings, meet people, find out all the different pathways to recovery, find out about, there's centers for people with severe mental illness, like West Winds in Pittsburgh, that you could go volunteer at. Be active in your education, and don't just take an idle seat to it. Because the best education you're going to get is if you're an active participant and seek more knowledge.
Yes, absolutely. I think what you said too, Brandice, about no matter where you go in nursing, you're going to come up with addiction. You're going to have to face it. I was a pediatric nurse for over 20 years. And who would have thought, as a pediatric nurse in a burn unit, you'd see addiction. But parents have addictions. And so it was a very family-centered care. And I found myself trying to get two parents to the methadone clinic in Boston on a Saturday morning when they got there on a Friday evening, with their child. So addiction is everywhere. It has no barriers. It has no boundaries. And I think that you just have to really go into it with an open mind. And I think what Brandice was saying as far as having the education and going to seminars, shadowing. I love the idea of shadowing someone, volunteering and seeing what's going on. I wish there was more of that, so people could really see what we do and how we do it.
And that's another opportunity to combat stigma when you're working with families, right? Because when you're working with families and kids, you're going to see parental substance use. And that's an area where the providers are really focused on the kids and are only seeing that family through the lens of the impact of the substance use on the children. And that's a really hard spot to be. One of the things that Spectrum's been a big part of is being the substance use, kind of provider, myself specifically doing supportive trainings for the kind of the medical community through UMass's Resilience Through Relationships grant and working with childhood trauma and parental substance use as a focus because, OBGYNs need that education, right? In viewing the parents in a different way and in understanding the stigma of addiction and understanding that and being able to approach, your patients' parents differently, right? Seeing them through a lens of kind of they were likely a traumatized child, right? Because trauma is so prevalent, in substance use. So training OBGYNs, pediatricians, providers in general is kind of another area to combat stigma.
And kids themselves are exposed to drugs at a young age. So seeing pediatric drug use and misuse is also kind of prevalent.
Yeah,
absolutely. And more so nowadays. I was listening to NPR on the way in, and the incidence of cocaine and meth use and overdoses in Massachusetts has gone up. And that's a frightening figure.
Very frightening figure, Michael.
Right.
So let's with some of the more time that we have, I'd love to to instill kind of some of the hope that comes up a lot in our podcast. So I know we've talked a lot about the combating stigma, the hard work, education, and we've talked a little bit about what motivates you all to do this work. And so one of the things I thought we could talk about is, what are some of the kind of, benefits to this work? When you see somebody improving, knowing that recovery is possible, can you talk a little bit about kind of what you've been able to support as a nurse and bear witness to?
I have so many stories. It would take a journal, but I can just think of this past week. I get so much. I'm learning so much in this program. That's the one thing I love, is that we never stop learning. And this is I started out with addiction, but then I went into a very high acuity positions, and now I'm back to addiction. And what I am learning is it's just incredible. Every day I learn something new, and how addiction has changed, and different methods and pathways that we have. And what I get from this is I spoke to a client yesterday in the emergency room, and he said to me, laughing, he said to me, "Michael, you are like having an ankle bracelet on. No matter where I show up, you call within an hour." I was laughing out loud with that one. I thought that was great. Because he knows that we are going to be there, that his team is going to be there. And it gives them, I feel, of course, it makes me feel great to hear them say these things, because as we said earlier, they're people and clients that have really not been treated well. And when they're having someone call and to check in on them to see how things are going. I had a woman 2 days ago say to me, I said, okay, myself and your care coordinator are going to check in with you every day into your PCP appointment, because I find her to be a high risk, medically, ill patient. And she says, "Oh, what do you mean?" I said, "Well, we're just going to check in." And she says, "Oh, okay. Well, I've never really had anyone care that much." And so those are the things you take that makes you say, "This is a good day," And I'm still saying it after 40 plus years. It's a damn good day. So
I always say, today will be over. It will never happen again. Even if it was the best day ever, even if it's the worst day of your life, know that this day will never repeat.
Right.
And tomorrow's a new day.
Right. Absolutely. And I was a float nurse for 12 years. So I got to say that every day because I knew I was never going to go back to that same floor. They were going to send me to another building, another floor, so it's you just get to reinvent yourself. You get to learn and learn and learn.
So I'm a big harm reductionist. So to me, even if somebody's still actively using and contacting me, like I had a client who clearly he's not a client anymore. This was years ago. And we kind of just evolved. And he still checks in with me, even though he's been in recovery for 3 years. He checks in with me every day. He, had a really bad relapse and almost lost his business, and his wife was pregnant. And I was like, "Hey, call me if you're going to use, because I know you use alone." And he would. And I made sure he was safe. And now his business is thriving. He has a daughter. He recently had a really good friend of his pass away due to an overdose. And he called me. He's like, "Girl, I know I'm going to call you or call somebody else, but I'm not going to use. I just saw it happen. I just saw somebody die." And I was like, "Good for you." I had a client, same thing, still checks in with me, even though I don't work at CHL anymore. And he spent most of his life incarcerated for, various things like mostly bank robberies, pharmacy robberies. And, he's not really the best at staying in recovery, but he's not on probation, he's not on parole, and he's not in jail, which is the first time he's told me in his whole life. He's like, "I wanted to go back to jail," he said to me. "But, I went into the bank and I was going to rob it, not because I wanted the money, just because I wanted to get arrested." But he said, "I thought to myself, what would Brandice say to you?" And he's like, "So I just talked to the teller, and I got a lollipop and left instead." And I'm like, A+. Like, that's how, this should be, right? Not, so just like little things like that just make me thrilled. Or like sometimes, like when I'm up on NERC Resi, Jesse, I'll hear the client say, "Oh, that nurse really cares. She's really good. You can go to her for anything." And I'm always like, yes, you can. And they do. They come to me with some pretty unique situations. I never say to them, "Oh, that's weird." Or I'm always like, "Well, I've never heard that before. Let me do some research." And Jesse will tell you, I will do research.
You will.
Yep, I will. So, and I'll find an answer. There was a mistake once on one of the handouts I did, and it said chapstick was used to prevent overdoses. So we kind of made it a group discussion and all did research, and it turns out it was just an error in where they put it under the.
But there's still a level of caring and concern and compassion that goes into that, because I remember that day specifically, and rather than just push it by the wayside or just keep on going, we never know. And I'm not speaking as a nurse, obviously, but speaking as someone in recovery that's worked in this field a little bit. You never know what type of impact you're going to have on a client day to day. You never know what one little thing can make a whole person's day or a whole person's stay with us. And, you talked about hope, Lisa, and I automatically go to my Rolodex of clients that I've seen while, being employed here at NERC. And, you see someone come in maybe with a really negative presentation and, really has a difficult time overcoming challenges while they're here with us. And, they go out and then we see them again for treatment, and they're a whole different presentation. They're a whole different person. That they really, I'm thinking, again, like you said, Michael, I can tell some stories, certainly not as many as you can over 44 years, but I'm thinking of one recently here from last week where, had we not treated that person when they were most acute, the way that we would treat anybody, even the most cooperative client, maybe they would not have came back. And we would not have been able to help them when they were less acute and more receptive to care. So I always look at it through that lens as well, as, maybe right now, my words are falling on deaf ears, or, I really feel like I'm not being heard, but possibly planting a seed for some time in the future.
I had
business.
Sorry, when I did outpatient, I had so many clients that would just like drop out of the program and you wouldn't hear anything from them. And then like 1 year later, they come back and they're like, I always remembered what you said to me, or how you went out of your way, or how you didn't judge me. And so I decided to just come back. And like, I would never say no to people, no matter what they did, even if they were diverting. Okay, well, let's come up with a plan this time. How can we support you better? And they would be like active participants in their recovery. And I think that's a big thing. Like healthcare and nurses really need to encourage them to be an active participant rather than telling them, well, you have to take the Valium at this time. You have to take your comfort meds. We'll see you later. Like, what comfort meds do you need now? Like, we're going to give you some Valium. It's going to make you sleepy, but you're going to feel better. I understand you feel like crap today, but, tomorrow we'll feel better. And just think, like one day at a time, right? So being an active participant, I think nurses need to be an active participant in their patients.
And what I'm hearing too is that every interaction matters, right? Every time you walk in the room, every time you encounter someone, every phone call you make, like every one of those interactions matter. And what a gift, right? To be kind of, someone that, you don't even know how many times, like you might know some that kind of continue to stay connected to you, or that will say, will thank you or say things like, but I multiply that by the thousands of folks that, you just had an impact on, and what a gift. I just recently listened to a podcast on happiness, and it was a researcher who actually had shifted careers, because what he learned about happiness as a researcher was that one of the biggest indicators of happiness is having purpose in your life. And I can't help but think about kind of the nursing profession as one that you get that purpose, from doing your work every day. And, not everybody can say that.
You're right. I think I want to say something about the nurses at Spectrum and particularly the dosing nurses, because when I started my position here, I had not dosed since 1980. And everything had changed, of course, the machines and all the computers and, everything was done on paper back then. But I worked as a dosing nurse for the first year of this program at Milford on Saturdays. And I started 2 months early to work at Weymouth to get a full scope of practice on what the nurses here do. And what I found incredible is that these nurses behind the counter, they only have 30 seconds or a minute to evaluate their client in front of them. And they are so in tune to their clients because they see them every day and who they are. They know if they might be intoxicated, who needs a breathalyzer, just the very quick assessments that our nurses do behind those counters every day for many, many hours and 7 days a week is remarkable.
And every interaction matters, even if it's
every absolutely day. Exactly.
Right. Yeah, that's amazing. I really can't, we're coming up to the end of the kind of our 45-minute mark, but this has been such a wonderful conversation. I've just really appreciated, getting to know you both, although I already knew you in some detail, Michael, but getting to really see from your perspective what that nursing role is. So I wonder if it would be a great way for us to wrap up. If somebody is thinking about either taking their existing nursing role and, either adding education or pursuing kind of some behavioral health or addiction nursing, or somebody just thinking about what career path they might want that might be rewarding. What would you suggest, folks do? Just get into nursing school? Like, kind of what would you suggest?
Let's go right ahead.
I would suggest, talking to a nurse. I always encourage people, like, even if nurses don't want to apply here, if you want to come talk to me and ask me about my experiences as an addiction nurse and as a nurse who went to school later as a nurse, going to nursing programs and talking to the teachers and asking them about that. But just do it. Like, why wait? If you're interested in it and you have a passion for it, like, why are you putting it off? Just try it, even per diem. And it's such a rewarding career. It's really so rewarding. So I always tell new grads, or any nurses, it's the most rewarding job I've ever had, more than the ER, more than the nursing home, more than hospice. I truly come to work every day excited to make a difference in clients' lives and in my staff's lives, and help empower them to make a difference in clients' lives. And I look forward to it. And, you want a job, if you think you're passionate about it, try it. That's the great thing with nursing. Look at all the experience I've had. I thought I would like to be an ER nurse. Hated every second of it, but what? I tried it. Go me. So, it won't hurt to try it and talk to people and just learn. And like I said before, no matter, even if you like it or not, you're going to find addiction anywhere you go. So it will give you that background to help treat patients with love and respect like they deserve.
And just to maybe in closure, I have never had a job in this profession since I was 20 years old that I have not loved. So that's an amazing, being able to say that as I'm getting closer to retirement, although I'm kicking and screaming.
We're not letting you go, Michael.
No, I have never had a job in nursing that I have not loved. So it's that to me says it all.
What is that saying? If you love what you do, you never work a day in your life.
Yeah, that's it. Yes. Yeah, absolutely.
So thank you both. Happy Nurses Week. We appreciate you. We value you. And this was such a wonderful conversation. Thanks so much for being on. So folks, if you liked this episode, please, like and subscribe and listen to all of our other Airing Addiction episodes.
And we will see you next time. Thanks, everybody. Bye-bye.
Thank you.